let's talk about an overview of what we're doing over here. Okay? So an overview. First, we're going to deal with general terms and tests that are in the, to deal with your urological disorders. Then we're going to do congenital urinary disorders. Okay, that's very short, interesting stuff. Then we'll get into voiding issues, incontinence, that stuff. And then we'll start getting into the diseases. Urolithiasis. What do you think that is? Litho. You did cholelithiasis, which is what? What's cholelithiasis? Gallstones, right? And now we're dealing with urolithiasis. So what do you think litho is? Yeah, these are kidney stones, right? Litho means kidneys, or stones, right? Okay? Infectious disease, urinary tract infections. Then we'll get into renal failure, okay? Then glomerular disorders and tubular necrosis. And then we'll do renal arteriosclerosis. We'll do that today. And we probably won't get to the neoplasm. There's only 2 on there, I want you to know, but we'll get into that later. Okay, so that's how I broke this up. Okay? All right, so let's just talk about general terms that we'll be using throughout the whole lecture here, okay, and also tests. So, urological terms. I did this with the GI system also. Nephropathy. It's a fancy word for kidney disease, okay? If you call about diabetic nephropathy, well, that's a progressive damage to the glomeruli due to diabetes. Glomeruli, that's the glomerulus. So it's doing damage to this, okay? Polyuria, we talked about that, which is peeing a lot. We could have oliguria, and that just means very scant or a little bit of urine coming out. Or we could actually have anuria, which just means you're not peeing at all, okay? We'll be using those terms. Then we have frequency. This is urinating often, usually in small amounts. A good example of this is someone who's pregnant, and they have this big baby that's pressing down on the bladder, so the bladder now is much smaller than it usually is, so it fills up very fast, and they end up peeing a lot, okay? We also have urgency. This is your urinary bladder it just wants to spit out urine, and if you don't go to the bathroom right now, it's going to come out. It's urgent that you need to go to the bathroom. That's how that comes up. All right, so you have the strong desire to go, otherwise you're going to go right there. Then we also have incontinence. This is the inability to keep the urine in your bladder, whether you control it or not. And then we also have nocturia. Nocturia is the consciously you get up in the middle of the night and need to go to the bathroom. So you don't wet the bed, you consciously, I feel like I have to go, and you go. Now, doing that once a night, even twice a night is okay, but more than twice, there's usually some other reason. And that happens a lot during pregnancy. That's an appropriate thing, right? We also have retention, the inability to empty the bladder either completely or partially. And then dysuria, that's painful urination. Hopefully you're not using any of these terms with your patients because they wouldn't know what nocturia is.
You have nocturia today.
They won't know what that is, all right? So you have to explain to them, and how often do you go to the bathroom? So you were just say like 4 times. So you write on your nursing notes, yes, nocturia is present, right? Same thing with dysuria.
You have dysuria today.
No, they don't know that. But, I mean, yes, a nurse or a doctor, sure, but they won't know that. Usually what you would say is, do you have any burning when you pee? Oh, yes, I have that. So then you got to put in layman terminology so they understand it. Okay? So that's what that is, dysuria. Okay? Then we're going to be talking about stuff that can be found in the urine that shouldn't be there. We have hematuria. That's blood in the urine. Okay? We also have glycosuria. Glycosuria is glucose in the urine. That's usually diabetics, right? They have so much glucose it spills in the urine. But we also see this too, and it's quite common in pregnancy. We'll get into that why later on, but very mild amount of glucose in the urine is okay. Okay, it's appropriate in pregnancy. Ketonuria, all right, somebody who has DKA, right, diabetic ketoacidosis. And this too, we talked about that breath smelling like a fruity acetone kind of smell, nail polish remover. The urine also smells like that too, okay, if there's that much. Okay. We also have proteinuria, albuminuria, all right. That means that there's proteins. Now keep in mind that strain. Let me go back to that strain that we talked about, the Bowman's capsule. Water's supposed to go through there, not the noodles. not the meatballs. Okay, those holes are not big enough to allow it to go through. But if there's some disease that starts eating at the strainer, and those holes get bigger and bigger and bigger, meatballs are going to go through there. All right? Same thing here. If that Bowman's capsule gets damaged, you will spill proteins, albumin, into the urine. That shouldn't be there. Okay? So that's telling us that there's some kind of disease going on. Okay? We also have bacteriuria, and that's bacteria in there, and also pyuria, which indicates infection. There's pus there. Now let me ask you this. If you have hematuria, you're going to have proteinuria. Why? If you're going to have red blood cells in the urine, it's also going to come up as proteins in your urine too. Why? Yeah, bingo! Love it. Right? Red blood cells have a protein in it called hemoglobin. Kudos to you. Okay? Yeah, so that's what it is. So it wouldn't make sense. So when people think of, oh, there's albumin in there. No, we don't know that. But if there's hematuria, there's going to be proteins in there. Now, it doesn't go the other way around. Just because you have proteins does not mean you have blood in there. Does that make sense? You've got to work that way. All right? You'll be doing this when you become a nurse. You'll be doing this kind of stuff. If not, I know for a fact that you'll be doing this when you become a nurse. You'll be doing this kind of stuff. So let me just introduce you to the urinalysis a little bit, okay? Urinalysis, there's two ways we could do this. We can either do a dip, and it's a quick test. It just, this over here, there's different colors on here, and each one of these blocks represents a certain thing, whether blood, bacteria, glucose, and so forth. Okay? And then it matches whatever colors they change, you have on the bottle itself kind of tells you the colors. Now, this is a good, quick kind of test. It's not an accurate test. It just tells you, is it there or not? It just tells you words like there's a trace amount, there's a moderate amount. You know, if let's say for a man, if you see that there's, you know, a mild amount of glucose, glucose should not be in the urine, and he's not pregnant. And if he was, I would definitely want to be his doctor. He'd make a lot of money, okay? But he's not, all right? The chances are he's a diabetic, all right? That kind of tells me with that. But this just tells you, again, just a very quick test to say, is it there or not? But we could send the urinalysis down to the lab, and they'll do more, go through a machine. And when that's done with the laboratory, it's more accurate. They're going to give you numbers, okay? And that's what that is. But as a nurse, you'll be doing this quite often, all right, to get ideas of what's happening there. So what does this urinalysis check for? Okay. Checks for color. Now, I'm not going to test you on this stuff. This is an FYI to introduce this stuff to you. All right, the color. Straw yellow is what it should be, right? You probably saw that. But they can change the colors. Red, think of red blood cells, right? Orange, certain medications will actually change that. Rifampin is notorious for making this almost like orange Gatorade coming out, fluorescent stuff, all right? Rifampin medication. Colorless, it could be like it's diluted, just made a very dilute urine. Transparency should be clear, but if it's cloudy, there could be pus in there. And that could be bacteria, okay? We could also have odor, right? I mean, you've all smelled urine before, right? Not the most pleasant thing. But just seeing a whiff of it can tell you some things about it, all right? If it's ammonia-like, think bacteria. If it smells, again, fruity, acetone, or like that nail polish remover, think of DKA, okay? pH should be around 6. It varies on the foods that you're eating and if you've been vomiting. Let me just finish up here, all right? If there's an increase of base, think of vomiting and stuff. But if there's an increase of acid, we're thinking more like DKA, acidosis, all right? Gout, because there's an increase of uric acid in your bloodstream that leads spilling out into the urine. So that's what's going on pH. But anyway, so any questions on this stuff here, right? Now this one here, specific gravity, this one you should know a little bit. Specific gravity is relative weight of volume of liquid compared to distilled water. In other words, does it float, does it sink? We're comparing it to water. So it should be less than 1.015, but if there's a specific gravity that's decreased, it usually means it's diluted, not much. But the key thing here is that if there's an increase of specific gravity, think pathology, all right? Think that there's some kind of stones in there, that there's blood in there, something is bringing it down. So that's where that comes in, okay? So anyway, questions on that, all right? Then over here, it's doing this kind of thing, the color, all right? Yeah, I guess they're not even doing it over here, it's sweet ammonia, over alcohol. Normal constants. Now, so what should be found in your urine? So you should have things with nitrogen in it, urea, uric acid, creatinine, right? These are all byproducts of proteins and muscle metabolism. They should be in there. And all your electrolytes should be in there too. All right, anything with a charge, this is just some of them, but they should all be in there. That's fine, all right? Abnormal stuff, stuff you should not see in the urine, okay? So glucose, right? That means diabetes. But again, keep in mind, mild glucosuria is okay in pregnancy. Albumin and protein should not be in there. They're too big to go through the Bowman's capsule. Unless the Bowman's capsule is getting destroyed, it is going to have seepage of proteins in there. Ketones should not be in there. Remember DKA, okay? Red blood cells and white blood cells should not be in there. Hemoglobin, which is red blood cells. Bacteria, pus should not be there. Nitrites, that's a little clue. They should be negative. But in certain bacteria, specifically E. coli is a good example of this, that's usually an early detection that there is a urinary tract infection going on. So if I see a person who's got burning when they pee, and I see nitrites, and I don't see any bacteria, but maybe a few white blood cells, I know something's cooking in there in terms of urinary tract infection. The nitrites are helping me on that. And nitrites might not be always positive because certain bacteria don't have a waste product of that, but E. coli, which is the #1 cause of urinary tract infections, does. Okay, so that kind of helps you to decipher. And then we also have casts. These are interesting because what it is if there's a lot of red blood cells that ends up going into the tubule, they kind of take the mold of the tubule and they go through the whole thing, and when it comes out, they actually are in casts of what the tubes are. I'll show you a picture. It's interesting on this. So abnormal constituents, okay? And this is where they're all on here. They should all be negative, all right? If they're positive, think of these things over here. And this is what a red blood cell cast looks like. Under a microscope, it kind of takes the shape of one of these tubules in here, and they come out in the urine as these casts. So it's really a cast of the tubule, and that's what's going on there. Does that make sense? Now you got red blood cell casts, there could be white blood cell casts. They coagulated in a way that they're actually formed. If they're going to sit in here for a long time, they're just going to take the form of the tubule, and then as it goes through here, it stays as this form, and it goes out your urine as these. You okay? Major diseases going on. Is that clear? You okay? Yeah, it comes out just like that. That's under microscope. Yeah. So it comes out like those casts. And there's white blood cell cast, there's red blood cell, there's a bunch of other things that come out. Yeah, interesting stuff. Okay? And then we have the culture and sensitivity, right? We talked about these before. Culture is that we're going to take a culture of the urine to see what bacteria is causing the urinary tract infection. And then afterwards, if it comes back as some bacteria, then we need to make sure, well, what antibiotics will be sensitive to that, so that we can kill it. And that's what a culture and sensitivity is, a CNS. Okay? Like a throat culture, same thing, except it's of the throat. You know why we do, you know what a midstream specimen is, right? Some of you don't. I did the other class. A midstream specimen is that you pee into the toilet bowl and then you stop. So you pee like, a little bit, you stop, and you put a cup there, and then you pee, and then you stop until it's full, and then you pee the rest in there. So it's midstream. What's the reasoning why we do a midstream collection? Yeah.
I know that it's like, there can be like a higher concentration of stuff in the beginning.
What? What stuff?
I don't know, something.
What? That's it. That's what we're looking for. What is it?
Protein,
No. No.
something.
Starts with a B, ends with bacteria.
Bacteria.
There, you see, I knew you knew it. Yes, bacteria. Okay? No, I know you know. No, but it is that, keep in mind, the urethra, the tube that goes from the bladder to the outside world, that has bacteria on it. All right? It comes, the penis is very dirty, so there's going to be bacteria going on the outside of the penis and start going into the urethra. Same thing with females, that the vagina has a lot of bacteria in it, and it's going to start crawling up on the urethra. So the idea of doing a midstream is that you're going to wash away the walls of the urethra by that stream of urine to wash it, and then hold it in, and now you got a clean area there, and then you can just collect a sterile specimen. Does that make sense? That's what a midstream specimen is. It's not this. Supposed to be a joke. Okay, different.